Good evening, good afternoon. My presentation is the burden and the challenge of heart failure management in China. Heart failure is a severe clinical syndrome with high prevalence. The prevalence rate has increased by nearly 50% in the past 10 years in our country. With high mortality, 5-year mortality rate is equal or worse than some cancers. High hospitalization, it is leading cause of hospitalization for the people at the age of over 65 years. The patient cannot get effectively managed. With high cost, the direct cost is 65 billion US dollar a year worldwide. However, in our country, annual hospital and outpatient expenses is over 35,000 Chinese yuan, equivalent 5,000 American dollar. Therefore, the burden is heavy. This is population-based study using record of 50 million individuals at the age of 25 or greater from National Urban Employee Basic Medical Insurance from 6 provinces in 2017. One province from each of 6 geographic regions was included: the North, Inner Mongolia, Northeast, Liaoning, East, Zhejiang, Middle South, Hainan, Southwest, Chongqing, and Northwest, Qinghai. The incidence of heart failure at the age of 25 or greater is 0.3%. At the age of 65 years or greater, 1%, and increased dramatically in the elderly at the age of 80 or greater is 1.7%. Therefore, the annual patient is about 3 million. The prevalence of heart failure at the age of 25 years or greater is 1.1%. At the age of 25 greater is 4.5%. And at the age of 80 years or greater is nearly 80%. The total patient with heart failure is 12 million. So this is the largest sample size with prevalence among individuals at the age of 25 greater is 1.1%. The total number is 12 million. Annually is nearly 3 million. The average annual hospitalization 3.3 times. The annually cost for hospitalization patient and outpatient is roughly over 35,000 Chinese yuan, equivalent 5,000 US dollars. That means the prevalence and the incidence of heart failure are high, resulting in a heavy social economic burden. The heart failure inpatient. This is from 169 hospitals from 31,000 patients. This ejection fraction among hospitalized heart failure patients. The mean left ventricular ejection fraction, 47%. LVEDD, 55. Half-pipe is the most common type. This research, similar to previous China clinical studies. Gender and age composition. The average age, 68. Male gender, 60%. The older people at the age of over 60, more than 3/4. The age over 80 years or greater accounted for 22%. The difference in blood pressure and heart rate with different type of heart failure. The average heart rate, 83 beats per minute. The half-life patient with higher heart rate than half-life. The heart rate over 70 beats per minute account for 83%. That means the beta blockers used is lower, especially target dose of beta blocker is much lower than that guideline-directed medical therapy. Etiology among patients with different types of heart failure, hypertension, and coronary heart disease are the main causes. However, the proportion of mild heart disease is relatively low. The cause of heart failure. Coronary artery disease is leading cause in half-life patients, followed by hypertension and dilated cardiomyopathy. However, hypertension is the leading cause in half-life patients. Similar finding from international research. Comorbidities among hospitalized heart failure patients. Atrial arrhythmia such as atrial fibrillation and atrial flutter accounted for 34%. Stroke, DIA accounted for 15%. Diabetes, 30%. Anemia, 27%. The standard drug used among hospitalized heart failure patients. The utilization rate of RAS inhibitor in half-life patients was 78%, significantly higher than that 10 years ago, similar to the finding from U.S. Heart Failure Registry. The beta blockers used in half-life was 79%, significantly higher than 10 years ago, similar finding from U.S. Heart Failure Registry. The MRI used was 84%, higher than that beta blockers and the RAS inhibitor, also higher than European and the United States. Implantable device therapy for hospitalized heart failure patients. The left bundle branch morphology 10% with coarse duration over 130 account for 25%. However, the rate of implantable device was much lower in half-life. It's only 2.1%. The reason may be the socio-economic condition, the medical insurance reimbursement policy, and the level of awareness among doctors and patients. Therefore, we need to increase the reimbursement of device implantation and increase education and training for the doctor and patient. That means increase the awareness. Mortality. Mortality in patients admitted to hospital with heart failure. From nationwide cardiovascular association database, this Heart Failure Center registry cohort studies. This is large sample size with over 327 individuals from 572 hospitals from 2017 to 2021. The most comprehensive analysis of prognosis in heart failure patients with different type, half-life, half-life, and half-mid range. The mortality at 30 days, 1 year, and 3 years was 2.4%, 14%, and 28% respectively. The causes of death in patients admitted to the hospital with heart failure. Cardiovascular deaths accounted for 72%, mostly myocardial infarction and stroke. Other factors associated with all-cause mortality include increased age and ejection fraction. Increasingly, with age, 1 year's all-cause mortality of patients aged over 80 or greater reached to 22%. Mortality increase with reduction of ejection fraction. The highest mortality is half-life. Other factors associated with all-cause mortality, including different types of comorbidities, anemia, CKD, COPD, diabetes, stroke, valvular heart disease, arrhythmia, as well as the drugs used for improvement of prognosis, such as ROS inhibitor, beta blockers, MRA. Compared to discharge from tertiary hospital, discharge from secondary hospital are independently associated with increased risk of all-cause mortality and cardiovascular mortality. Although guideline adherence score is also independently associated with increased risk of all-cause mortality and cardiovascular mortalities. How to improve guideline-directed care of heart failure? Our initial experience is to establish heart failure center through heart failure center to improve guideline-directed care. 5 major systems of China heart failure centers include certification system, quality control system, information-based system, scientific research system, and education and training system. Heart failure centers have covered all provinces in the past 7 years. They registered hospital over 2,500 with accredited hospital 911 submitted cases over 900,000. The diagnostic level has improved significantly in heart failure center hospital, with utilization rate of lateral radicopeptide up to 95%, the rate of echocardiography up to 85%. Therefore, the diagnostic rate improved, with improved misdiagnosis and missed diagnosis reduced. The drug used for improving prognosis has also increased markedly, with ROS inhibitor up to 81%, beta blockers up to 91%, MRA up to 81%, therefore significantly reduced mortalities. The proportion of anticoagulation therapy for heart failure patients with atrial fibrillation has also increased markedly from 16% to 19%, therefore reduce the risk of stroke. Guideline expert consensus and some research. 4 essay papers have been published with IF over 10. 2 guideline, 2 group standards and 2 quality control reports have been achieved. 12 expert consensus have been published. Conclusions: heavy socio-economic burden of heart failure in China, high prevalence and incidence. The prevalence at age of 25 years or greater was 0.1%. The total number over 12 million. Annually increase 3 million. High cardiovascular and total mortality. The mortality is equal or worse than the cancers. High rehospitalization, annual hospitalization 3.3%, and high cost. What to do for this challenge? Our initial experience or initiatives is to establish heart failure center. Through heart failure center, improving diagnosis of heart failure. That means diagnosis of echo and biomarkers up to 90% some decrease the initial underdiagnosis of heart failure. Improve the utilization rate of prognostic drugs in heart failure center hospital. The drug used for improvement of prognosis, such as beta blockers, RAS inhibitor, MRA, up to over 80%, associated with reduction of mortality and readmission. Thank you for your attention.